Hello, welcome. Thank you for joining the Zooming Through ID. I'm Dr. Gopal, an infectious disease specialist here practicing in South Florida, trained at Duke University, been here at Broward Health North for 20 years. I'm the medical director for infection control and I chair the antibiotic stewardship for the four Broward facilities. I'm an infectious disease attending here at Broward North. And one of the most rewarding parts of my work is teaching internal medicine residents as well as infectious disease fellows. This session is a short, focused teaching forum where the residents and fellows take ownership of their learning. The they either I will assign them a topic or they pick a topic of interest and they do extensive research, literature review, and then they teach us in this session. Today we have a very interesting topic, and the presenter is Osama, and he has put in time and effort to prepare this topic, and he's going to talk about it. And the topic is about mucormycosis. So let me introduce you to Osama. Hi. Yeah, you can.
Hi, hey Dr. Gopal, hey everyone. Dr. Zayzoon. I'm Osama Bushama. I'm a BGY1 internal medicine resident at Broward Health North. Um, so I met Dr. Gopal on my elective rotation in infectious disease, and I encountered this interesting case that we're going to talk about today. Although I'm very interested in pursuing a cardiology fellowship in the future. But this case was in particular very interesting, so I decided to do a case report, case discussion with Dr. Gopal, and here we are.
Yeah, that's awesome. Can start sharing. Yeah, so this session definitely, it has to be, it's critical thinking, and you think about what is the importance of the topic and take home for the bedside knowledge as well as for the boards. Okay,
Okay.
right.
All right. Um, so we have the case is mucormycosis in the setting of DKA. Is my name. Let's go. All right. So can you see my screen?
Yes, yes, we can
All
see
right.
now. Perfect.
So this patient, she is a 73-year-old female with a history of COPD, type 2 diabetes, hypothyroidism, hyperlipidemia, hypertension, tachycardia syndrome, status post pacemaker, who presented to the emergency department with worsening of shortness of breath and hypoxia. According to the patient, she has been in her usual state of health until the day of presentation when she developed progressively worsening dyspnea at rest associated with increased work of breathing. On admission, she denied chest pain, palpitations, syncope, or hemoptysis. There was no reported fever, chills, or recent sick contacts. She was found to be hypoxic on arrival and required initiation of BiPAP for respiratory support. On presentation, her vital signs were notable for hypertension, blood pressure of 157 over 91, tachypnea with a respiratory rate of 32. She was also afebrile and she was maintaining oxygen saturation while on BiPAP. Um, so immediately, what we were thinking about is multiple things. When someone comes in with acute hypoxic respiratory failure and hypoxia, so we usually think about COPD exacerbation, acute decompensated heart failure, PE, pneumonia. Those are the big um, headings that we think of. Pneumonia, sepsis, DKA, ACS, and fungal infections, since the patient is She has a long history of uncontrolled diabetes and hyperglycemia. So we're also thinking aspergillus and mucormycosis. So the labs and imaging that were ordered, including ABG, VBG, BMB, lactate ketones. We also ordered CBC, BMB, troponins, chest X-ray, CTBE, AKG, and blood cultures. Um, so the results came back for pH was 7.26, bicarb was 13.7, anion gap was 21, glucose was 330, AST 180, ALT was 70, alkaline phosphatase was 194, BMB was slightly elevated 526, procal was 2.776. White count was 17, hemoglobin 11, which was the baseline. We also got urine analysis, which showed glucose was positive, ketones were positive, specific gravity was elevated, nitrites negative, leukocyte was negative, and red blood cells white count was minimal or none. So that raised the concern for high anion metabolic acidosis and diabetic ketoacidosis. So also we ordered imaging, which gave us the diagnostic clues in a patient who came in with acute hypoxic respiratory failure and hypoxia, as well as on the labs, she was found to have DTA immediately, and that also comes up on the board exams a lot as mucormycosis. So CT chest was ordered, which showed right upper lobe consolidative lesion, 5.3 centimeters, cavitary component, small bilateral pleural effusions. X-ray chest showed stable right upper lobe mass, which was cavitary. CT sinuses, of course, to rule out any necrosis, showed paranasal sinuses are clear. Here's the X-ray, and it's very amazing how it shows the right upper lobe cavitary lesion here. Um, and we have the CT scan as well, which showed also the cavitary lesion in the right upper lobe. Um, so the microbiology, we got sputum from the trachea, which showed which was positive for rhizobus and candida. We did also bronchial wash from the right upper lobe, which showed candida albicans and rhizobus and enterococcus fecalis, which was isolated. Um, Additional information: the blood cultures were negative. So that patient was luckily in a still in a good spot because her the CT of the nasal sinus was negative, and she was still in the early stages of the rhizobus infection. Um, so interval history for the patient. The patient was admitted to the ICU, of course, for DKA treatment. She was stabilized and then was transferred to the floors. Um, Mid-surge and then acute rehab to continue further management. She was vitally stable throughout her hospital course, tolerating her medication as well. And then we also trended the labs, and they were improving. Was controlled, creatinine stabilized, and white count was trending down. So let's talk a little bit about the patient management of of antifungal infections. So basically, for those patients, it's very important. The first line treatment is to start them on amphotericin B. We start with 5 milligrams per kg IV daily. That's the first line, and the minimum duration is 2 to 3 weeks IV, and then transition to oral step down when the patient clinically improves. So we always have the step down options. When the patient improve, we have the conazoles agent, posaconazole, isavuconazole, and for these medications, we have to also keep an eye on their levels in the blood. For antibiotic coverage, and this is should be tailored according to each patient. For this patient, for example, as we mentioned earlier, that she had the Enterococcus faecalis and the Candida. So, based on her culture, we started her on Mirum and Doxy until we ruled out any bacterial infection. We also need to mention the supportive care for these patients, especially daily monitoring of renal function, because amphotericin B, as we know, it causes electrolyte imbalance and AKI. So we have to keep an eye on amphotericin B, eye on the renal function and electrolytes. As well as for this patient, she had acute hypoxic respiratory failure, so we needed to keep her on oxygen supplementation as needed and then wean off. For blood glucose control, DK resolved. We continued the subcutaneous insulin, and of course, so some patients they come in. It's a very invasive disease and very rapidly can become very invasive. So we have to also have surgery on board. So for surgical debridement or if needed. So for this patient, it was deferred as there was no invasive disease confirmed. And also we have to follow up and monitor with serial CT chest scans to track lesion resolutions. And also repeat culture until we ensure that the fungal infection is cleared completely, and monitor for any antifungal toxicity, um, which we did. And so let's talk about the as well as before moving to the characteristics and facts. Uh, let's talk a little bit about the predisposing factors um, for this kind of infection. So most importantly, we need to mention that DKA. It's one of the most important factors that could cause um, um, mucormycosis. And second thing is immunosuppression, as well as prolonged steroid use. So the bottom line is any immunocompromised patients, organ transplant patient, neutropenic patient, patient with iron overload, right, and chronic lung diseases. And from that, let's move on to the Mucorales characteristics and facts. So it's a fungi, Rhizobus mucor and leukemia. It is ubiquitous in soil and decaying matter. It's very angio-invasive. It causes tissue necrosis, rapid progression, and high mortality, especially in immunocompromised, as we mentioned earlier. Predisposing factors are the uncontrolled diabetes, hematologic malignancy, neutropenia, immunosuppressive therapy, solid organ transplant, um, and the clinical presentation for these patients, they usually come in with cough, dyspnea, hemoptysis, fever. It's pretty non-specific, but we have to keep in mind the predisposing factors along with the clinical presentations. Uh, it,
Add one thing to the predisposing factors, these, the newly added, COVID-19 associated mucor, because some many patients we had during the pandemic time, COVID-19 patients, we had to give prolonged use of steroids, and then subsequently they had mucor, just to add that.
yeah. Okay. Yeah. Interesting. And we have the clinical presentation, so fever, hemoptysis, cough, dyspnea, and rhinoorbital cerebral, sinus pain, facial swelling, disseminated disease, multi-organ involvement. So these are the pretty much the clinical presentation for these patients. So let's talk about mucormycosis management per guidelines. So, according to the guidelines, the first line is, as we said earlier, is the liposomal amphotericin B. We start with 5 to 10 milligram per kg every day. And then the step down options are, as you mentioned earlier, the conazole agents after the clinical improvement, surgical debridement for invasive disease. These are the three lines that we always have to keep in mind for in managing any mucormycosis case. Um, and the adjuncts that usually comes with this with the disease is patient with uncontrolled glucose. So we need to make sure that there's diet glucose control. And if any patient is on steroids and immunosuppressants, we have to stop that if possible. And then for renal function, we always have to keep an eye on the electrolytes and renal function, magnesium, potassium, daily during amphotericin B. Um, and I remember in particular, like when I was working with Dr. Gopal, she made sure that every day we get the CMP panel for the patient. And the duration is some guidelines they say 2 to 3 weeks. Some guidelines say at least 2 to 8 weeks, which is guided by clinical response and imaging. Um, we also have to make sure that there's hydration to protect the kidneys. And regarding the fluids, we usually do pre and post hydration with IV fluids. Normal saline is the preferred fluid, 500 milliliters normal saline, 30 minutes before infusion, and 500 milliliter normal saline after infusion, which according to studies, it reduces nephrotoxicity and hypokalemia, which is associated with the amphotericin B. Um, a third thing is the amphotericin B, which can cause the nephrotoxicity again with the electrolyte losses. So hypomagnesemia, hypokalemia, so we replete as needed. Um, we also have to make sure that while the patient is on amphotericin, we need to be cautious with other nephrotoxic agents such as aminoglycosides, vancomycin, NSAIDs while on amphotericin B. The other thing is we need to always adjust the fluids based on the volume status of the patient. Again, so every patient has different volume status, so we need to tailor it according to the patient. And amphotericin B therapy, I'm sorry. Yeah, so we need to make sure the electrolytes are repleted, especially potassium and magnesium. We don't want these patients to go into um, heart arrhythmias and cardiac arrhythmias and neuromuscular issues during therapy. So we should always get frequent labs daily, early in treatment, and yeah, at least daily. So the learning objective was from this case is to review the clinical presentation of pulmonary mucormycosis, um, recognize the predisposing factors, especially for DKA, discuss differential diagnosis in patients presenting with dyspnea and DKA, and understand the current IDSA and ECMM management guidelines. Um, and that concludes my presentation. Any questions?
No, this was great. I mean, the key, like you were talking about, I mean, all mucor cases, I mean, it is seen rarely, but definitely you have to recognize that. That's the key. And amphotericin B is the drug of choice. And like you were talking about daily labs, it's very important.
Yes, of course. My my preferences and guidelines, it's mainly up to date. open evidence, including CDC, and other guidelines and journals. Um, John Hopkins Antibiotic Guide, and I leave them here. So if you need to go over them. That's it. Any questions?
That's good job. I mean, you did very good. The other important aspect is debridement. Like you were talking about surgical debridement, this angio inversion and eschar. So always medical therapy along with surgical debridement is the key. And ampho-B, as you know, we have to keep the patient in the hospital and watch the electrolytes very closely. And renal failure is one of the most, it's difficult, when, if they have, if they get renal failure. So we have to be watching very closely.
Yeah, of course.
Yeah.
Yeah, and I remember like when I was with you, we were every day monitoring
Yes.
those levels. And
And then the patient actually did amazingly well, and it was very very good, but the prognosis and mortality rate is high because of the angio invasion, and mucor recognition is important, and treatment is important, and it's rare. So it was a great topic and excellent job, great work.
thank you.
So okay.